Thanks for the invitation to be part of this meeting. As you said, I'm going to show you a case in a box with the Hydra valve. But before that, allow me to give show a few slides on what I think is important when you choose a valve nowadays. And we also know that these valves are certainly not the same. So I think contemporary expectation for a valve used in TAVI include to have a low rate of new permanent pacemaker, low rate of paravalvular leak. There should be easy access to the coronary arteries after valve deployment, and the valve also needs to have a good durability. And the issues about pacemaker and new onset conduction abnormality all comes down to this close proximity between the aortic annulus and the AV conductions. So we know it's only separated by the membranous septum located between the right and the non-coronary cusp. So particularly for a stent frame which have a tapered configuration, there's a higher risk that is going to interfere with the conduction system and lead to new left bundle branch block and even permanent pacemaker. And we now have seen robust data that both left bundle branch block and new permanent pacemaker after TAVI is related with increased cardiac mortality and hospitalization for heart failure. Also, paravalvular leak was an issue, particularly in the beginning of the program, and we know if the patient have more than mild paravalvular leak, that is associated with a higher risk of all-cause mortality. So it's also very important to choose a valve which have a low rate of significant paravalvular leak. And then again, access to the coronary arteries is important, both because about 1/3 of these patients have pre-existing coronary artery disease. And also, if the patient will live longer, we need to be able to access these coronary arteries in case of acute coronary syndrome. We saw that re-access study presented just 2 years back, very simple study. 300 patients undergoing TAVI. Operators was asked to cannulate right and left coronary arteries before valve implantation, implant the valve, and then re-access the coronary arteries. And particularly for one platform, for the Evolut platform, we saw that in 1 out of 5 patients, it was impossible to access both coronary arteries. So of course, again, this is not going to be an acceptable outcome after a TAVI procedure. And then the final issue, we need to have a valve with a good durability. And what is the main driver for early valve failure? That is that the patient will receive a too small valve. If you have patient-prosthesis mismatch, it's going to be a driver for not only early valve degeneration, but also for cardiac-related mortality. So moderate patient-prosthesis mismatch will lead to a 30% increased risk of cardiac mortality. And if you have severe PPM, it's more than a 6-fold increased cardiac mortality. So one of the new players on the market is this Hydra valve from India, which tried to fulfill all these criteria for what is asked for a contemporary transcatheter heart valve. It's a self-expanding technology made from nitinol, got a supine leaflet position, it got big stent cells, and it got a straight and not a tapered inflow portion of the stent frame. So it both offer very flexible system. So if you have tortuous anatomy, acute angulation of the aortic arch, horizontal aorta, this is a very nice valve to use. Large stent cells means it's easy access to the coronary arteries. It got a low profile, so it can go in a 14 French comparable inline sheet. And self-expanding technology with a supine leaflet position is going to give you optimal hemodynamic outcome, low rate of PPM. And then again, the cylindric inflow portion have less interference with the conduction system. And I'm just going to show here some recent data on patient-prosthesis mismatch, particularly for patients at risk. Patient who got a small aortic annulus defined as 23 millimeter or less. If you use a balloon expandable technology as a Sapien valve or my valve, you can see in these patients, 25% of the patient will come out with severe PPM. If you use a self-expanding technology, it's only 3%. So it certainly makes a difference what kind of valve you choose in patients with small aortic annuli, which are not uncommon in India. So these are my last slide here, the data from the Genesis trial, which led to approval in India with a Hydra valve. You can see it have excellent hemodynamic performance, very low mean gradient, 6.7 millimeter mercury, large effective orifice area, 2.3 square centimeter as expected for a self-expanding technology with a supine leaflet position. Pacemaker rate, including all patients without pre-existing pacemaker, 7.5%, so really in the top of the group here. And also very low rate of significant paravalvular leak, more than mild in only 2.9%. So I will stop my presentation here, and we got a recorded case demonstrating how to use this valve and how easy it is actually to implant it. So if I can ask the organizer to start this case.
So welcome to Copenhagen, where we're going to show you a transcatheter aortic valve implantation using the novel Hydra valve. My name is Lars Sondergaard. I'm here with my two colleagues, Ginter Spilauskas, Ole de Backer, and also have here our scrub nurse, Louise. So maybe we can start with a case presentation. So we're going to demonstrate a transcatheter aortic valve implantation using the novel Hydra transcatheter aortic valve. The patient is an 82-year-old female, normal body size, height 156 centimeter, weight 50 kilogram. She got multiple sclerosis. She got a history of gastrointestinal bleeding. She's also awaiting a resection of some bladder polyps. And she was referred to us due to symptomatic severe aortic stenosis. She's now in function class 3 and also got some peripheral edema. So we did an echocardiography confirming the diagnosis. There was a severe aortic stenosis with an opening area of 0.4 square centimeter, high gradients, peak gradient 140, and mean gradient 90 millimeter mercury. LV was hypertrophic with moderate impaired systolic function. Ejection fraction is 40%. ECG revealed sinus rhythm, normal PI interval, but incomplete right bundle branch block with a QRS duration of 128 milliseconds. Coronary angiography showed no significant stenosis. Her lab findings showed moderate impaired renal function with a GFR of 42, and her STS score is 5.8%. CT scan showed a relative small aortic annulus. Perimeter-derived diameter is 22.2 millimeter, and this dimension is the same as what is found in the left ventricular outflow tract. Sinus valsalva is quite large, and ST junction, also no issues, it's 26.27 millimeter. And you can see here it's a severely calcified aortic valve, and we believe it's a tricuspid aortic valve, even though some views may indicate it could be a bicuspid aortic valve type 1, but I think it's a tricuspid valve. Coronary height is fine. Right is taking off 15 millimeter above the annulus, and the left 13. You can also see here under the right there's a big chunk of calcium. So these are the implantation view, the three-cusp coplanar view, and the right-left cusp overlap view, which we are going to use. REO 17, Cordal 38, so it's certainly a doable implantation angulation. Aortic arch is quite challenging. There's some acute angulation in it, and you can also see there's an abnormal takeoff of the neck vessel. I believe there's a separate takeoff of right subclavian artery and the right common carotid artery. So in this case, we are actually not going to use a cerebral embolic protection. We're going to use a transfemoral access. It's suitable. The vessels are a bit tortuous, but good size and no calcium. Right sides have a minimum diameter of 7.8 and left more than 8 millimeter. So the plan will be to do a transfemoral transcatheter aortic valve implantation in local anesthesia, no sedation, no anesthetic team in the room, using the right femoral access. We're going to start with pre-close with 2 pro styles. Then we introduce a standard 14 French introducer sheet because the Hydra valve's delivery system is comparable with a 14 French sheet. We're going to do right ventricle pacing due to this incomplete right bundle branch block. We're going to do pre-dilatation due to the severe calcification with a 20 millimeter balloon, and then implant a 26 millimeter Hydra valve. So this is how it looks like. This Hydra valve is a self-expanding technology, quite large stem cells, which of course facilitate easy access to the coronary arteries, but also make the valve very flexible if you have tortuous anatomy, acute angulation of the aortic arch, or if you have horizontal aorta, it's also quite easy to get coaxial alignment. The leaflets are mounted in a supine leaflet position. It's 3 leaflets made out of bovine pericardium. And you can see here at the upper part, you have those 3 tentacles which are used to attach them. the valve to the delivery system. And this just to show that the valve currently comes in 3 sizes, 22, 26, and 30, covering aortic annulus diameter between 17 and 27 millimeter. This patient had an aortic annulus of 22.2, so that's nicely for an Hydra 26 millimeter valve. So back to here, Ole, you can show us what you have done so far.
And then on the contralateral TAVI side, we have just a venous access because we're going to pace, of course, on the RV pacing. And then we have a 6 French access for our pigtail.
Yeah.
And then now we're going to make the puncture for TAVI. We know from CT we want to aim mid-femur head.
And we're going to do it ultrasound guided. So let's demonstrate how we can do this. So I think this is now state of the art for vascular access to use ultrasound guided puncture. It's going to give you a better chance to have a good access in the middle of the artery in a position where you have no calcium, and thereby the chance that your pre-close system is going to work is higher. So you can see here Oles have identified the common femoral artery, and he's now putting some local anesthesia in, and he can also use the ultrasound to guide where actually to position it just above the vessel. And next, of course, doing the access here with a standard needle. Again, remember the patient is fully awake. There's only local anesthesia. There's no sedation for the patient. So, of course, good local anesthesia is really important here. And now you see the needle is coming down. You can see Ole is now here just in the middle of the artery. So I think that's a good calcium-free position. And then you have the guide wire. So this is a way to do it nowadays. So next here we're going to first introduce a standard short 6 French sheet, and then we're going to deploy the 2 Pro-style devices. Jo, vi kan lige med. So so Ole is introducing. You see, is blood coming out. Now he's in the vessel. Open that pedal, pull it back. Here 1 o'clock. Deploy the needle, coming out again, and cut the suture. And then we have the 2 Pro-style deployed. And we can now go in with you have a sheet here, which is a 9 French sheet. So this Hydra 26 millimeter is the delivery system is comparable with a 14 French sheet. So that's why we're starting with a 14 French sheet here. We use the Syntron sheet from Medtronic, which I think have a nice profile, and also it's quite hydrophilic. We wouldn't expect any major issues here because the vessel was quite large and non-calcified, and see that 14 French sheet is coming nicely up.
Nice, yeah.
Okay. Next we'll introduce the RV pace lead. And again, as I said before, this patient got incomplete right bundle branch block, so that's why we want to have RV lead instead of doing LV pacing. So we can check the pace. So if you pace 100 in a second, so start pacing. What's the output?
Okay, go capture.
That's fine. Okay, come off pacing. So
I can go in.
So next we introduce the pigtail catheter.
do another. Yep.
You're in the non-coronary.
Yeah. All right, good.
You can already now see that it's quite calcified aortic
very
valve here.
calcified.
So now I think we're ready for crossing the valve. We went to the crossbore lab view, which in this case is REO 15, caudal 35. And this is actually also not only for implantation of the valve, but also a quite useful view to crossing the valve, because we know that we need to search just here on, in this case I would say just on the right side of the pigtail catheter. Yeah, well done, Ole. So, and also as a default here in this institution, we cross with a straight guide wire and an AL1 catheter as a first choice, and then we're going to change for pigtail catheter. So Ole is just trying to advance. You see, it's very calcified. It's hard
deeper down with your wire.
to bring the catheter further in here.
So you can go deeper.
But then we're going to put an exchange wire in. We're going to put a pigtail catheter in. And the reason we use the pigtail catheter is, first of all, to have assessment of the degree of paravalvular leak afterwards. The patient is treated under local anesthesia, so we cannot do a transesophageal echo. So we're going to rely on aortic root injection as well as hemodynamic assessment. So pigtail catheter, I would say, will give you a better hemodynamic assessment. You will have a recording of both the diastolic pressure in the aorta and the end diastolic pressure in the LV, and we can repeat that after valve deployment as part of the PVL assessment. Second, I also think it's a more safe wire to introduce the stiff wire in a minute into the patient with a lower risk of getting entangled in the mitral apparatus. So now the pigtail is going in, and we can hook up to the second pressure line, so we have simultaneously recording in the LV and in the aorta.
Holding.
Yeah, it's really very calcified. Huh?
Yeah.
Coming.
It passes nicely.
Good. Yeah.
Careful.
And
are we entangled at the tip?
there's certainly a high gradient, no doubt about that. Severe aortic stenosis. So we got a gradient of 124 millimeter mercury, so really severe. Diastolic pressure in the aorta is 42, and end diastolic pressure in the LV is 24. So we're going to recall these two numbers and compare it after valve deployment. So next is to introduce the stiff wire. Again, as I said before, we're using the pigtail catheter to have a good position of the wire in the LV without risk of getting entangled in the mitral apparatus. I hope that's sitting nicely. This is a stiff wire from Boston Scientific. It's the Sapphire guide wire. It's pre-shaped wire, comes in 4 sizes. This one is the smallest one, the extra small. And then I think we are ready for pre-dilatation. We normally respect the minor axis of the aortic valve, and in this case it was 20 millimeter. So the balloon is a 20 millimeter balloon. This one is from Usipka balloon. And we can do pacing in a minute. We can pace 160 max output here and start pacing. Pressure's down.
Yes, that's enough.
Yeah.
And
okay. And you can come off pacing.
Fluoro safe this.
Back up pacing.
Yeah.
So you saw that just the balloon inflation caused a 3rd-degree AV block here. We knew the patient was at risk due to the pre-existing incomplete right bundle branch block. And that's, of course, is also why we choose to have an RV pace lead in this case.
She gets her own rhythm back there.
Yeah. Then try to come down now and see whether she's back here.
Can we have the dilator on maybe?
Dilator.
Yeah. Okay. So I think she's back now.
Yeah, she's back.
Yeah.
Okay, good. But it shows she's very fragile conduction system.
Yeah.
Completed.
Now we take the Fortune Friends sheet out, which is comparable with the size of the delivery sheet for the Hydra valve. you can zoom in here, we have this nose cone, we have the capsule. At the end of the capsule, there's a radiopack ring here. And then you have the inline sheet here, which make it 14 French comparable.
Let's make it nice, wet, indeed. Somebody holds
Holding.
the sheet.
Holding the wire. Holding. Du holder wire, Lars.
Okay. That goes very smooth in. Yeah. Okay, no problem. Okay, I'm continue.
You hold yourself. Yeah?
Yes, you hold the wire.
Yeah, we hold the wire. I can take over here. It's our wire.
Goes very smooth in, actually. Nicely hydrophilic, I have to say.
Yeah. And also it's a very flexible system. You will see it'll take very tortuous anatomy, acute angulation of the aortic arch very easily.
We need to go LAO.
And also if you have horizontal aorta, it's a quite nice valve to use. You can get coaxial alignment almost no matter how challenging the anatomy is.
You see there on the pigtail, it's a much more steep arch than we can kind of, like this. All right, ready?
Ready.
I'll go slowly here.
And often you will see that small kink on the stent frame, which make it...
Yeah, we'll finally make that small kink there. Yeah. Feed the wire a little.
Yeah.
It's okay, Ollie, it's okay. It's okay. I'm giving you some negative rail.
Yeah, so I took it nicely, yes, the arch.
Yeah, and I'm railing constantly.
Okay, now I go to cusp overlap again.
So we're going back here for the implantation view in RAO 15 and caudal 35. So here we often see very little parallax in the delivery system. So we see the nose cone, we see the radiopack ring.
Yeah, all right, that's true.
And then you see those two set of markers, the 3 markers at the first intersection and the 3 markers at the third intersection. So what we want to aim for is to have these 3 markers just above the aortic annulus at the final deployment. That's going to bring the valve about 4 or 5 millimeter below the aortic annulus. And particularly in this case, where it's severely calcified, we may foresee that a post-dilatation may be needed. So we won't aim to sit extremely high here. So I can also just show the handle here. You see there's this knob. You go, the principle go counterclockwise to deploy the valve, counterclockwise to recapture. And then we have the black one here. So if at the end when the valve should detach from a delivery system, if that's not possible, this is actually an active mechanism to detach the tentacles from a delivery system. So maybe we should just start here. We'll just have an injection just to see where we are, because there's quite a lot of calcium. So there's a risk that the pigtail is not sitting all the way down in the bottom of the cusp. You see there's a chunk of calcium a little bit lower.
You can use the calcium as we deploy instead of injections, actually.
So we should probably go a little bit. So I think that will be an ideal position to end up if you can.
Okay, that's a good spot to start.
So Gintis is now slowly going counterclockwise. You see that radiopack ring is now leaving the nose cone. The first part of the capsule is empty.
We may need some pacing.
Yeah, we will do that in a minute. Just wait, Gintis, don't go too fast. Just give a little bit of time for the force to
build up. Yeah, it's a acute arch, so it takes some
so there may be
time.
So try to pace.
Say a lot. To be honest.
Try to pace. Wanna? Okay, that's fine. Just continue pacing here, and we'll pace a little bit faster when we come to the middle phase where the stent frame is flaring out before we got annular contact. So you can go up to 130 here.
One small contrast
injection. You can do that. I think that's okay. Again, remember you have all that calcium below where the pigtail is sitting. So just go, just stay that pacing. You go up to 140.
Continue.
we're on a deeper side. I haven't.
No, I don't think so.
It's okay.
No, the calcium is lower than the pictal, it's through.
Yeah.
Okay.
I think it's fine.
Pressures are low, but they will be recovering.
And you can go down to 120. Go down to 100. Stop here.
Yeah, I would stop
And
here too. We go to an
try to come off pacing. Let's see.
This is a line.
So now here as always, it's important when you implant in this Cospo view to confirm in this view that you're actually below the aortic annulus. Yeah.
Yep.
So we can just see the top and here. Now, if you pull the stem wire a little bit back,
Let's move on.
yeah, yeah.
Let's give some backup pacing, please.
Yeah.
80.
So I go further to release.
Yeah.
We are in agreement, yeah? Pressures are coming back, so they are slightly...
Pacing, it was the rhythm.
And we want to see those 3 tentacles coming off. I can see 1 is off now.
I'm at a hard stop.
You go to full stop.
So,
okay?
so if you rotate on the black one here, counterclockwise, and take that screw off,
Totally off.
yeah, pull it out, and you go counterclockwise on the black one.
Oh, it's
it's free, yeah.
actually,
But that's a way to bring
Yeah.
it free. So it came off here.
Yeah, it helps really.
Good.
Yeah.
So
Okay,
I think we're ready to come out.
Let's keep the wire in.
Keeping. I'm trying to, manipulate your nose
Yeah, but
cone.
push the wire out. Yeah. Thinks it's nice. I mean, let's see in.
Er ballon klar, hvis vi skal bruge det?
Okay.
Yeah,
Should we
and
wait?
we
Let's
can
reload.
close here. So you go opposite here now on the blue one. To bring again, close the capsule, bring the nose cone down to the sheet. Maybe. Yeah. And then we can have the 14
Regular
French sheet
is
back
ready,
in. And we can do our assessment whether anything further is needed.
Yeah, we are closed,
Okay,
I
that's
think.
great.
Yeah.
Yeah. Okay.
So 14 French sheets going back in. We can have the pixel into the...
It's very constrained. I would immediately...
Yeah, should we just do maybe we should just do a post-dilatation here.
Yeah.
So what balloon did we decide on? Should we use
22,
22 balloon?
Use
Or
that
we can
20
use the same?
initially.
Yeah, maybe let's use the 22. I mean,
20, okay.
yeah. So you saw Ole was leaving the pigtail in the non-coronary cusp.
Let's go a little bit away from the.
Quite simple to bring it out again. It's just using a standard J-tip guide wire and push the wire all the way in and then bring the pigtail back. Yeah. Okay. Going in with the balloon. This time it's
You hold the wire.
it's an
Holding.
true dilatation balloon from BART. It's at least a semi-compliant balloon. It's really fast to inflate and deflate, and it will take you to the nominal
Coming soon.
diameter.
Be careful, be careful.
I know.
So we probably need a little bit more faster pacing here. With pace 220 when we're ready.
Okay, pacing on, please. Yeah.
Good capture, we agree.
Yeah. Yeah, go and down. I wanted to avoid
Stop pacing.
LVOT on purpose.
Stop.
Stop pacing, yeah.
And I go down to back up. That gave a nice expansion of the valve.
Yeah.
But again, it was foreseen. It was so calcified that we might need to do a post-dilatation.
That was very good. I think
Also, just eyeballing on the calcium here, I think you have a very nice position. Only you're about 4 millimeter below the annulus,
so
which is
too,
exactly where we want to
or
be.
even 2, 3 there, I think, on the non.
Yeah. So let's put a picture into the LV. Let's do some hemodynamic assessment, and then let's do a aortic root injection.
There.
Yeah, we are just eyeballing. It looks like we got a nice separations between the diastolic pressure and end-diastolic pressure. We can do some recording. We had 42 before in the aorta. We got 50 now. That's better. We got 24 in the LV. We got 23. So this certainly does not indicate any significant.
Rather small anatomy, no gradient. I think it's also important here that we don't have a gradient.
We have a reverse gradient.
Yeah.
So we'll record this, and we can do an aortic root injection. We can maybe Mac 1 and move the table a little bit. Yeah, what is that? Mild?
Mild, I would say.
I think that's certainly acceptable in an anatomy like this.
Extremely calcified.
And I won't be more aggressive with the...
No.
Good.
Indeed, size is good, position is perfect, post-dilatation is adequate, so there's not much else.
So let's show how to close the access vessels. So will you just tell us what we're doing? You have those two.
Yeah, the two
with
styles I have now. I'm going to just pull on it. So we keep the wire in.
6 inches.
No. Then somebody can also give me the pushers. Oh, they're there.
Pushers are there. So just release one, take a pusher. It's going to be fine. As long as you pull, there's no bleeding.
So one way to check whether you have hemostatic stasis is to go crossover from the contralateral side with a EMA catheter and do an injection. So in this case, we have a stiff wire, an Amplatzer super stiff. And we leave that, it's still in there, and all it again is just put a 6 French sheet in, take the dilate out, and we can use that for contrast injection to see whether we are
8-4. 8-4.
Looks good here externally.
Perfect.
Looks nice,
looks
yeah.
Fine.
So nothing else needs to be done here?
No.
So again, I think we complete this case. You saw it's a very challenging anatomy. It's first of all a small anatomy. It's important to make sure that the patient will not have patient-prosthesis mismatch. Using a self-expanding technology will ensure the best hemodynamic performance and probably also the best durability. You saw how calcified the aortic valve was, and with this valve, it actually did a very nice, only traced to mild PVL afterwards. The inline sheet makes it 14 French comparable and very smooth procedure here, no vascular complications. So thank you for joining us here.
That's a very well done case. Dr. Lars, from your experience, when do you recommend a self-expanding valve versus a balloon expanding valve?
I would say particularly what everyone is talking about today is the durability of these transcatheter heart valves. And as I said before, the patient who are particularly at risk for early valve failure are patients who are left with patient-prosthesis mismatch. And we have seen now numbers of meta-analysis showing that self-expanding technology is going to give lower risk of PPM and probably better durability than balloon expandable valves and surgical valves. And also, if you look at the balloon expandable valves, data also show that even surgical valves are giving better durability than balloon expandable valves. So identify your patient at risk for patient-prosthesis mismatch. And again, it's patient with small aortic annuli. I guess you see quite a few of these patients in India. These patients, I would strongly recommend you to consider to use a self-expanding technology.
Okay, a very nice presentation, Dr. Lars. Actually, in your case, we have seen by negotiating the aortic arch bend, lot of tension is over the wire. So what is experience this Hydra valve, especially when negotiating the bends? Any difficulties how you overcome?
Yeah, again, what is a nice thing about this valve, it's very flexible. I mean, the stent frame can make a kink as you come around the aortic arch. So even though you have acute angulation where some of these valves will put a risk for vascular complications in place, it's almost never the outcome here with this valve. It's not the case. It will negotiate acute angulation. I also said before, if you have patients with horizontal aorta where it can be difficult for some of these valves to get coaxial aligned, this valve, pushing a little bit on the wire, pushing a little bit in on the delivery system, we'll just put the valve on the side and you'll have nice coaxial alignment.
Thank you.
Just one question from my side, Dr. Lars. We have so many self-expanding valves, and this is one more new addition there. So in your experience, do you think it has really made a difference in terms of reducing the PPL and the complete heart block, which we generally see? And what is the data, what you think about with this valve?
Yeah, I was
others?
trying to highlight that in the beginning here, that even though you must say it's a self-expanding technology with a supinflated position, as you will find with the Evolut system, I would say, first of all, the inflow portion of this stent frame is cylindric, where the Evolut is tapered. So that's why you have a much lower pacemaker rate with this valve than what you see with the Evolut valve. Also, you saw that the stent cells are much bigger here than it is with the Evolut valve. So access to the coronary arteries is much easier with this valve than it is with the Evolut valve. We saw from this Italian re-access study published in 2020 that about 1 out of 5 patients treated with the Evolut valve, you will not be able to access the coronary arteries afterwards. And to me, that's a completely unacceptable situation. Just imagine the patient will come back with acute coronary syndrome and you cannot get into these coronary arteries. So that's something which certainly needs to be fulfilled when you choose a self-expanding technology.
Does the Hydra valve allow easy accessibility to coronaries at a lower height? What is the cutoff value for height of coronaries, especially the left coronary?
Yeah, I mean, I don't think you can give a number for that, because it's going to be a combination, not only how high is the coronary taking off, but also how wide is the sinus valve and what is the height up from the valve to the ST junction. But as a rule of thumb, I would say we want to see about 10 to 12 millimeter high takeoff. But even though in some cases you have a lower takeoff, if you have a very, how should I say, wide sinus valve, you will still be able to access the coronary arteries afterwards.
Anybody has a question for Dr. Lars? We have a couple of minutes.
I think it was an excellent presentation, and we got to know about this new valve and learned so many things about this new valve, because this is just newly introduced in India also. Hopefully it will give us a better deliverability and more easy way of delivering this valve. So thank you very much,
I'm sure
sir.
it will.
So we close the session. Thanks to Dr.
Thank you.